flexion contractures of the PIP joints of the fingers are one of the most difficult problems we hand surgeons face. All flexion contractures are a result of an imbalance of forces across the joint. Either there's too much flexor force or not enough extensor force, or a combination of the two. Secondary to these force imbalances, the PIP joint moves into a flexed position. The soft tissues on the palm side of the joint and the capsules of the joint itself shorten. On the extensor side, the skin lengthens, and unfortunately with time, the central slip itself of the extensor mechanism lengthens and becomes progressively incompetent to extend an otherwise healthy joint. Like the hand therapist splints in cerebroplaster casts, the Digit Widget applies an extension torque that stimulates the longitudinal growth of the contracted palmar soft tissues. Unlike splints, this device transmits torque directly to the skeleton, thereby avoiding pressures that prevent traditional approaches from reversing the more difficult contractures. While this device will reverse any contracture with compliant soft tissues, the surgeon must identify and reverse the cause of the force imbalance, both on the flexor and the extensor side of the joint. Without restoring balance of these forces, the joint flexion contracture will rapidly return.
Remove the Tyvek lids from Pack A. Under the Tyvek lid of the inner tray is a sterile condensed surgical guide that can be referenced by the doctor or nurses in the sterile field. This condensed surgical guide contains step-by-step instructions for the bone pin and pin block installation. Inside the tray there are two pre-drills, the distal and proximal pre-drill, two bone pins, the distal and proximal pin, a hex wrench, the drill guide, and the pin block. Select the drill guide and place it on the middle phalanx of the involved finger with the word distal oriented towards the fingernail. Use fluoroscopy to confirm the proximal pin will be placed just distal to the articular cartilage of the PIP joint. Mark the skin at the proximal end of the guide. Select the proximal pre-drill. Prior to drilling, take care to center the drill guide on the dorsum of the finger so the drill will follow an axis that projects parallel to the proximal phalanx. Then, using a power drill, insert the proximal pre-drill through both cortices of the middle phalanx. The surgeon must securely hold the drill guide on the finger during drilling. Disengage the chuck from the pre-drill. Do not remove the pre-drill from the bone. Use fluoroscopy to confirm that the proximal pre-drill is placed correctly. Next, select the distal pre-drill. There are three fine lines etched on the distal pre-drill that indicate the maximum depth to place it into the drill chuck. Ensure these lines are visible after chucking. Securely holding the drill guide, use a power drill to insert the distal pre-drill through both cortices of the middle phalanx. Remove the distal pre-drill from the bone, but take care to maintain alignment of the drill guide with the pre-drilled hole. Now select the distal bone pin. This pin is the shorter of the two pins and has finer threads and has the word distal printed on the top of the black knob. Manually insert the distal pin into the pre-drilled hole. It should extend through but not beyond the palmar cortex of the middle phalanx. Remove the proximal pre-drill and select the proximal bone pin. It is longer, has coarser threads, and has the word proximal printed on the black knob. Insert the proximal pin into the pre-drilled hole so that it extends through but not beyond the palmar cortex of the middle phalanx. Confirm correct pin location and depth using fluoroscopy. If needed, make adjustments to pin depth prior to cutting off the knobs. Once satisfied with pin depth and location, make initial cuts just below the pin's shoulder to allow for drill guide removal. The pins will be trimmed to final length after the pin block is installed. Now select the pin block and hex wrench. Use the hex wrench to loosen the pin clamp screw a couple of turns. It is not necessary to completely remove the screw. Slide the pin block over the pins until it sits approximately 3/16 of an inch above the dorsum of the finger. This spacing allows for some swelling. Use the hex wrench to tighten the clamp screw onto the pins. Cut off the pins so they are flush with the top of the pin block. If the patient has had an open procedure along with the application of the Digit widget, it may be preferable to wait a few days to a week before starting the extension torque. If the Digit widget was the only procedure, the torque may be started immediately. Choose the appropriately sized cuff for your patient. Each cuff fits both left and right hands. Place the cuff on the hand with the smooth side towards the skin. Position the distal edge of the cuff directly over the MP joints. Wrap the distal strap across the palm and attach near the base of the thumb at wrist level. Wrap the proximal strap across the back of the hand and through the thumb-index web space. The connector assembly is then snapped onto the pin block, and the Velcro tab is attached to the distal edge of the cuff over the MP joint of the involved finger. The extension torque is created when an elastic band is placed on the posts. One post is located on the pin block and the other on the connector assembly. In general, start with a single lightweight band that the patient wears continuously. If after a week or so joint extension is not improving with a single lightweight band and the finger is not painful or excessively swollen, change to a medium or heavyweight band. An extension gain of 10 to 20 degrees per week is desirable. Monitoring range of motion by measurements and graphing the changes, along with notes about band strength and the hours the device is worn, help in the decision-making process. Pin care and flexion exercises are best performed with the extension torque removed. Detaching the connector assembly from the cuff or removal of the elastic band both remove the extension torque. For showering or washing the hand, the connector assembly can be removed from the pin block entirely by stabilizing the pin block with one hand and pivoting the connector assembly distally. If the patient is to be performing flexion exercises, it is best that the extension torque be removed so that they are not exercising against resistance. Keeping the hand clean and dry should help prevent pin track problems.